Hello, and welcome to a new episode of A Cancer Conversation with the Georgia Cancer Center at Augusta University and Wellstar MCG Health. I am your host, Chris Curry, and today's topic is going to be breast cancer. October is recognizing Breast Cancer Awareness Month, so we wanted to sit down with a breast cancer survivor to share her experience and her story. Her name is Erin Chrisco. Erin, welcome to A Cancer Conversation, and thank you for the opportunity to share your story with our listeners.
Thank you so much for having me, Chris.
We are honored to have you. Of course, you are not just a breast cancer survivor, but you're also the breast health nurse navigator for the Wellstar MCG Health Breast Health Center. And I met you when I first joined the Cancer Center because at that time you were a nurse navigator for our breast cancer care program. So I think it's safe to say that breast cancer is something you feel very passionate about, and especially when it comes to being a resource for our patients.
Yes, absolutely. We've been at this a little while, haven't we?
Yes, we have. So I started in 2017, and you were already here at the time. So talk to me about why breast cancer was the kind of cancer that you chose. Before we talk about your diagnosis, I want to get a little bit of background about you just to let the people know who you are. So talk to me about the decision to focus on breast cancer, because obviously we have nurse navigators for all of our different cancer types here at the Cancer Center. So why breast cancer?
Well, when I first became a nurse in 2007, being a cancer nurse, period, was not really part of my plan at all. Didn't know much about it and really didn't have any desire to involve myself with that particular disease type. But what I did know was that I loved women's health. And I started off my career at University Hospital in the Women's Center. I spent my first year as a nurse working nights in the Women's Center. And very frankly, had they ever been able to offer me a day shift position, I may not be here now. So I guess it's a good thing that they weren't able to do that.
Yes, we're glad.
Yes, but nonetheless, I love women's health. I've always loved women's health. I worked at University Hospital for a number of years, and the reason that I left was, unfortunately, budget cuts were hitting everywhere, and the position that I held at the time was being done away with because of budget cuts, and I found myself needing to, of course, have a job. So I managed to get a job in one of the private oncology practices right here in town. And I was a chemotherapy infusion nurse. And it was at that time, it was 2011, I absolutely fell in love with cancer patients. To say that they are unique is an understatement. They approach their diagnosis and their treatments with a grace that you just don't see in other disease types. And I absolutely fell in love with oncology. I became an oncology certified nurse through that position. And then I stayed there for several years. And then about 2014, a nurse that I had worked with in a previous job called me and she said, "Hey, I've got a great job for you if you're interested." And I said, "Well, what is it?" She said, "Well, the Georgia Cancer Center is hiring a nurse navigator. They need a nurse navigator to be split between their GYN oncology service line and their breast service line. And I think you'd be perfect for it. Would you come and interview?" And I said, "Absolutely, yeah." So I did, of course, accept the position. And when I started, I was split between GYN and breast. Several months into that role, the other nurse navigator for breast was promoted, and that vacated her full-time breast spot. And of course, my team asked if I would step into that full-time. And that's how I got into breast specifically, and I've been there ever since.
Now, let's talk about your diagnosis, because obviously you've been helping women with mammograms at the Breast Health Center, and before that as a breast nurse navigator for the cancer care program. Talk to me about your cancer diagnosis of breast cancer. When did that happen? How did that happen? What's that story?
So it's definitely unique. Of course, in the imaging center, we are accredited by the American College of Radiology, ACR as we call it. And every year the ACR does a review of our program. For that review, our radiologist is required to submit a certain number of imaging sets. And of course, they're able to select the imaging sets that they need. It was Thursday, April the 17th, when I overheard my radiologist say to our lead technologist, I need some more images. I had just turned 40 on April the 2nd, and I told my lead tech, I said, if she needs more images, do my mammogram. I just turned 40. Yeah. So again, it was late in the day. Patients were gone. I mean, we don't do imaging that late in the day, just because if there's anything else that's needed from a screening mammogram, we want to have the time to do it. But anyways, there it was, just tiny little calcifications on my mammogram that Dr. Panzita saw, and she just said, and she wasn't quite comfortable with them. She said, let's do a diagnostic, and then she said, let's do an ultrasound, and then she said, let's do a biopsy. I said, okay. So we did the biopsy on Monday. That would have been April 21st. Okay. Very grateful to my friends in pathology who were able to get me an answer quickly. And it was DCIS, or a non-invasive form of breast cancer, that was initially biopsied. Okay. Of course, from there, my friends at the Georgia Cancer Center, including our wonderful breast surgeon, Dr. Alicia Arnold,
who we have interviewed before on this podcast.
Yep, she is my colleague, my friend, and my patient. She's wonderful. I love her. I cannot say enough about Dr. Arnold. So, of course, I text her. I said, "Hey, I need a breast MRI, and I want to see you. Can you order that?" And of course, she did. And I had my MRI on Wednesday, the 23rd. So again, biopsy Monday. Results Tuesday, MRI Wednesday. Thursday, I needed 3 additional biopsies. Dr. Panzita read that MRI, and she was recommending 2 additional areas in the breast and a biopsy of a lymph node. Thankfully, the lymph node was benign. One area in the breast was also benign, but there was a very small area that ended up being invasive cancer. So all those biopsies were done, and after that, I had my surgical consultation with Dr. Arnold, and she is always such a strong advocate for breast-conserving therapy, because it is true. There have been so many advances with our treatment plans and our treatment protocols where surgery is, part of it, that not everyone needs a mastectomy, but she is so gracious to also allow patients their choice. And at 40, with these other areas that were biopsied and of concern, I just didn't want to have to follow it. So she graciously allowed me to choose my own course, of course, with her approval and permission, and within the guidelines. But ultimately, on May the 14th, I did have a unilateral left mastectomy. Along with a sentinel lymph node biopsy, and thankfully all the margins were negative. Lymph nodes were all benign. So this was found very, very early from a screening mammogram that I didn't even know I needed right at that moment.
What was your reaction when Dr. Panzita was like, I know there's some spaces we need to take a closer look at here? Because you're just thinking, oh, I'm going to get this done. I'm 40. You're not thinking that this is in your future, and all of a sudden, here we are. What was going through your mind? How did you process that?
Well, I kind of had to take a step back and breathe for a minute. Again, this is something that I help other women through on a daily basis. But it's different when you're talking about yourself.
Yes, I imagine it is.
Yep. But so, I had to remind myself that I was with the best team possible, and that whatever it was going to be okay, because we knew how to deal with it, whatever it was. And I had the best team on my side. Because
you don't know it's cancer right then and there. We got to do a little more testing, a little more exploring before we determine exactly what it is.
That's exactly right. Because a lot of our imaging, even on patients that we recommend biopsies for, the vast majority of them come back non-cancerous. So it is it's a relatively small amount of patients who end up being diagnosed with breast cancer just based on the sheer volume of biopsies that we do every year.
So you talked about a screening mammogram, and then you talked about a diagnostic mammogram. Can you talk to me about the differences between those two?
Absolutely. So a screening mammogram, when you hear women say, "Oh, it's time for my annual mammogram," This is someone who's not having any issues, no concerns, nothing that they're feeling, no new lumps, no bumps, no nipple discharge, skin changes, nothing. It's just time for their annual screening mammogram. It's the most basic mammogram. It's 2 views per each breast. And again, it's just screening is the best way to say it, because that's exactly what it is. If something comes back abnormal from the screening, like what it did with mine, at that point, it's the time for a diagnostic mammogram, which is still a mammogram, but it just has some additional views and gives the radiologist a better view of what they initially saw. Another reason to have a diagnostic mammogram, some women actually need that prior to screenings. So like our younger women, if they are feeling something that's concerning, as long as they're 30 or older, they can have a mammogram, but it would be a diagnostic because there is a concern. There's a concerning issue.
So obviously 40 is when the traditional screening guidelines start, but women should be doing self-exams all the time anyway, just because you never know when something's going to pop up.
So we follow our national screening guidelines. The NCCN guidelines is the guidelines that we follow for our screening protocols and for how we make our recommendations to patients. Yes, 40 is the starting point for women who are at average risk for developing a breast cancer over their lifetime. Well, how do you determine someone's at average risk? Yes. You have to do a formal risk assessment. We actually have it's called the Tyrer-Crucick screening model that we use. It's the
Tyrer-Crucick screening model.
Yep, TYRER-CUZICK, Tyrer-Crucick screening model. Okay. It's the most comprehensive model currently available. It takes into account a patient's own personal history as well as their family history and compiles that information and then gives an estimate of what their personal lifetime risk of developing a breast cancer would be. So let's say someone who is 35 started their menstrual period at age 10, didn't have children until after age 30, and had a mother who was diagnosed with breast cancer in her 50s. That person is going to be at a higher risk than someone, again, who perhaps started menstruating a little later, doesn't have that family history of breast cancer, had children prior to the age of 30, all those someone who has not taken hormone replacement therapy over their lifetime, all those types of things play into a person's risk. So when we find that someone is at higher than average risk for breast cancer, the guidelines, of course, are different than they are for someone who is at average risk. The guidelines would typically recommend that you don't start mammograms prior to the age of 30. But there are some cases where women need to have their breast examined imaging-wise prior to the age of 30. Let's say that their mother was 35 when they were diagnosed. Those guidelines would say 10 years prior to your first-degree relative. So at 25, that patient would potentially be eligible to start doing screening breast MRIs up until the age of 30, at which time a mammogram would be added to that annual screening protocol. With breast cancer, unfortunately, we don't really have a great way to prevent it outside of dramatic surgeries that are not appropriate for everyone. So our best tool is early detection, and that's why we pride ourselves at our institution to make sure that every woman who comes in is able to get that risk assessment, and we're identifying these high-risk patients so that they can be screened earlier. In my conversations with a lot of our referring providers, early on in my time at the Breast Health Center, I was able to form those connections with those providers to stress the importance of early detection and finding out, is your patient high risk? Because, again, you're getting a risk assessment with us when you're coming in for imaging, but you're not coming into us until you're 40. So the time to catch you is in your 30s when you're seeing your OBGYN or you're going for your annual family health visit family medicine visit. And those doctors will email me, call me, and say, hey, I have this 32-year-old. Her mom had breast cancer at age 45. Can you do a risk assessment? Absolutely. We do those on the phone with those patients all day long. And if they need to come in for screening earlier than age 40, we get them in.
Erin, so you mentioned the Tyrer-Crucick screening model. You're the one that actually does that screening for people at the Breast Health Center. Is that correct?
That's right.
And had you ever done it on yourself before this episode?
I had, and I was average risk. No family history of breast cancer, did not start menstruating early, had children prior to the age of 30, breastfed my children. No real significant risk factors for me. But again, it's not an exact science, but what we have to remember is only about 15% of breast cancers have anything to do with hereditary features. 85% are random. So it's important still that we have that information about risk status, because if you are high risk, we can start your screenings early and things like that. If you're not high risk, again, thanks to the good Lord, I had my screening when I did, and that's just part of it.
And it's as simple as a woman or a man, because we will touch on that a little bit, but breast cancer can also happen in men. It's way less common, but can happen. But women just need to have conversations with their primary care doctor or their OBGYN. Is that right?
That's right.
Okay. And then they get in touch with you and sort of set up that referral process.
Absolutely. So Georgia law indicates that screening mammograms can be done by self-referral, meaning that a patient doesn't necessarily have to have a referral from a physician for a screening. Now, I want to be very clear about something. While we don't need a physician's order specifically in the state of Georgia, there has to be a physician to be responsible for the results. So, if a patient has a physician and they go to their annual and that physician is able to give an order, that way we know where to send the results, that's ideal. But if there's a patient who is, she just calls and says, oh, I don't see my doctor until December, but my mammogram is due in October. Can I schedule my mammogram? The answer, historically, yes, you can. But who is your doctor? Because if there is a finding and diagnostic imaging is needed, at that point, it does require a physician's order. So we have to have a physician or a physician or a mid-level, like a nurse practitioner or a physician assistant, someone to be responsible for those results and to be able to follow up with them. Because in the imaging center, we are a referred service. We are not a primary care provider. While we do follow up and close the loop on our patients, we have to know that they are under the appropriate care provider.
Talk a little bit more about just how important screening mammograms are. Let's really drive that point home, because I think, today in life, people are so busy. They have so much going on, whether they have kids or pets or jobs or families or boyfriends or whatever. But screening mammograms can save lives.
They saved mine. Like you said, I'm very, very blessed. I have a wonderful husband. I have 3 very active children, all under the age of 15. I have a full-time job, family in the area. We're busy constantly. And, to be very honest, had we not needed those images for ACR, maybe I wouldn't have gotten my mammogram right when I turned 40. But the reality is, because I got my mammogram when I did, this cancer was able to be found early enough to where it was a stage 1. Because I had a mastectomy, I did not have to have radiation. But the big point, chemotherapy is something that's always, in the back of someone's mind when they have a cancer diagnosis. So in breast cancers that are found this early, the doctor will send it off for a test called a mammoprint. And what it is a genetic study on the tumor itself. And that the information from that test will give the providers an indication on what will that patient's benefit from chemotherapy be. And in my case, that mammoprint came back showing that I would actually receive a less than 1% benefit of a risk reduction by undergoing chemo. So, of course, that made it very clear that in my case, chemotherapy was not needed. My tumor was very much hormone driven. So I do take an estrogen and progesterone blocker. It's called tamoxifen. A lot of people may have heard of that medication. But again, every breast cancer is different. Treatment for all breast cancers are very individualized. So, my journey is not going to be the next woman's journey. But I was very, very fortunate because of my screening mammogram that I was able to have, the Cadillac of breast cancer treatments. I mean, really, that's what I feel like I was able to receive.
So obviously you're dealing with patients, you're giving them pieces of advice, things to remember, things to think about, things to focus on. What were those things for you? What kept you going and focused on this happened? We now know it happened, but now we need to take care of it. What kept you going and sort of focused on the road ahead?
First and foremost, it was my faith. I grew up in a Christian home. I've been taught very well for my entire life that Jesus not only saved me from my sins when he went to the cross of Calvary, but he also took on all of diseases, anything that would ever come about in my life. He's already taken care of it. And, the Bible tells us that, it tells us in Matthew, if you have faith but as small as a mustard seed, that you can say to any mountain or any obstacle, move from here to there, and then it has to obey you. I mean, the Word of God tells me that nothing will be impossible if I have just this much. Look, just that much faith. That's the mustard seed. Here you go.
Okay.
I've been able to share this with patients as well. Not forcing it on any, but anyone who, asks me that question, I'm asked that a lot. When patients find out that I've been through this, they said, how did you do it? How did you get through it? It's definitely, it matters what you believe. It matters what you think. It matters what you believe. Mindset is so important. That's really the biggest thing for me to stress to anyone is just mindset is important. Happiness is a choice. Well-being is a choice. Could I have decided to crawl in a hole and hide my face? Sure. Would that have done me any good? No.
How about support system? What was your support system like? Because not only the person diagnosed with cancer having to focus on the path, but we also have talked about how important support systems, whether that's family, friends, churches, social circles, book clubs, talk about how important support systems are in general, but also for you.
Oh my goodness. They are huge. Again, as a wife and a mother and having day-to-day things that you have to deal with outside of a cancer diagnosis, it's stressful enough as it is. But then to add this, I have the most wonderful husband. I'm a little biased, but I have the most wonderful husband.
I'm sure you do.
Very supportive and, again, very similar upbringing in terms of faith. We've had this conversation many times. I mean, we're on the same page with what we believe. And he was right there to say, he said, Jesus has this. We've done, this has been taken care of. We're not moving off of it. And the same thing with my mother, my grandmother, my pastor, my sister. I didn't share this information with a whole lot of people as I was going through it, most of all because I do also believe that life and death are in the power of the tongue, and I didn't want people talking about it. Okay, so, just a very close circle of friends and supporters who I knew would be supporting me in line with my belief system. So who you have in your circle is very, very important.
And I want to wrap this up with the most important information. What does someone who needs a screening mammogram need to know? How do they make an appointment with you and your team?
So for us at the Wellstar MCG Breast Health Center, it's just as simple as reaching out to our scheduling team. The phone number is 706-721-9444. 9729. So it's one X-ray. You know, now that we are WellStar, there have been some changes with the way that scheduling is done, but that piece has remained the same. Although you call that phone number, you will actually be speaking with a scheduler who is located in Marietta, Georgia. But they will be able to set you up for your screening mammogram. Again, a physician's order. The state of Georgia does not require it for a screening, but WellStar personnel may ask you about the order, and of course they're going to ask you about which doctor needs to get your results. Of course, if there are ever any issues with the scheduling part of care, they can call us directly. My number is available all over the internet. See if I can remember my new number, 762-375-4267. So I'm in the office. Our office is actually closed on Friday, but we're there Monday through Thursday every week. So scheduling department first, but if you have any issues, you're welcome to call me directly.
Well, Erin, we appreciate you taking the time. Thank you so much for sitting down with me for this conversation to talk about not only breast cancer, but your experience, your story with breast cancer. I appreciate it.
Well, thank you again for the opportunity. I really appreciate it.
And if you have any questions for Erin or anyone else here at the Georgia Cancer Center, or you have topics that you would like to see us discuss, you can send us an email. That email is cancer, then the @ symbol, and it's augusta.edu. That's AUGUSTA.edu. And of course, we will do everything we can to get your questions answered. We have lots of experts in lots of different types of cancer, so we want to know what sort of information you want us to cover. So please do that. And of course, A Cancer Conversation is produced by Lindsay Morris and Amanda Bryant. It is edited by Will Hayes. We are a member of the Augusta University Podcast Network. You can find our episodes on YouTube, Spotify, Apple Podcast, and Amazon Music. Thank you for joining us, and we will see you next time.